Hello, my dear menopausal friends. I'm so glad you came back to join me today. And that's because today's video is really important. You know that I present everything you need to know about menopause, and my goal is to empower you with all the information you need to succeed in managing your menopause your way. Now, no two women are alike, so it's critical for you to know all your options in all categories for managing your menopause. That's why I present your options in every single category: diet, lifestyle, vitamins, minerals, supplements, herbs, hormonal medications, and non-hormonal medications. Now, I'm a real nerd. Not only have I gotten educated in all those areas myself, I also deliver this material to you in a very nerdy, academic, organized order. That's the only way it can help you. You know, if you learn something without first learning all that came before it, you will definitely create problems for yourself that could have been avoided simply by watching these videos in order, starting with the very first one. And that's all I will say about that today. Currently, we are covering a unit on osteoporosis. It began in video 196, and here we are in video 224, still talking about osteoporosis. Beginning with video 211, I started giving you all your management options for preventing osteoporosis, falls, and fractures. And that was after I'd schooled you in everything you need to know about osteoporosis, falls, and fractures themselves. So far, I've given you the management options in all the categories except the non-hormonal medication category. So that's what we'll discuss today. In my book, this material is in chapter 29, which is the osteoporosis chapter, under the heading Non-Hormonal Medication Options. It's in chapter 29 whether you have the first edition or the second edition. Doesn't matter which book you have. Now, the reason you definitely need to know about these non-hormonal medication options is because preventing or treating osteoporosis is not easy. You may need more than just estrogen, or you may not be able to take estrogen, or you may not want to take estrogen. But no matter what your preferences, I guarantee that you do not want the fractures that come with untreated osteoporosis. So no matter what, please watch this video. If you don't need to utilize any of these options now, just tuck this knowledge away so that you can access it later if your situation changes. You know, it's really a fortunate thing that we have options for preventing and treating osteoporosis in the non-hormonal category. As I've taught you, bone loss is a direct result of estrogen loss. So it's understandable that estrogen can prevent or replace bone loss. But to have so many non-hormonal medication options is just great for women who need more than just estrogen or something instead of estrogen. And the great thing is that there is a whole smorgasbord of just these non-hormonal options. But like everything else, they involve trade-offs. They do not all have the same benefits or risks, pros or cons. And that turns out to be another fortunate thing. The very fact that they have so many different pros and cons makes it easier for you to find one that's best for you. So I'll go through and present each of these non-hormonal medication options for osteoporosis, and we'll create a chart as we go along. I like to show you the chart as it develops because you notice details better that way. If you've been watching my videos in order, starting with the very first one, you'll recognize these non-hormonal medication options as belonging to a group of medications called SERMs. I first introduced you to the SERMs in videos 34 and 35. But some of what I taught you then has changed. It's been 3 years, and 3 years in terms of what we can learn about a medication is a long time. So even if you watched those videos, pay close attention to this one. You'll learn some new information. Now, I don't expect you to recall the acronym SERM and what it stands for. That is, unless you're an ultra nerd like I am. So here's what it means. S is for selective. E is for estrogen. R is for receptor. And M is for modulator. So SERMs are selective estrogen receptor modulators. Whew, that's in a mouthful, isn't it? Well, now I'll translate that into a language you can understand. Way back in video 25, I taught you about receptor sites. So let's pretend that this is a cell in your body. And this cell has receptor sites for estrogen. In other words, an estrogen molecule can attach itself to the cell and occupy this receptor site. But estrogen is the only thing that can occupy it. It's an estrogen-only receptor site. So estrogen is the only kind of molecule that can fit at this site. Unless something else resembles estrogen enough that it can impersonate estrogen and occupy an estrogen receptor site. An estrogen imposter. And that's what SERMs are. Estrogen imposters. So a SERM can occupy this estrogen receptor site. Now, let's change our terminology a bit to address the details of the acronym SERM. Instead of using the term receptor site, let's use the term parking spot. Receptor sites are nothing but parking spots. They're parking spots for hormones, but they're very picky about which hormones can park in the spot. So certain cells of your body have receptor sites or parking spots for estrogen only. Estrogen receptors are estrogen parking spots in your bone. And because your bones are so dependent on estrogen, they have a lot of parking spots for estrogen. Your bones love estrogen. So this explains the E for estrogen and the R for receptor in the acronym SERM. Okay, now let's address the word selective. Here I have a parking lot. Here I have a parking lot with cars in it. And you know how it is when you go to a strip shopping center in your car and you're driving around looking for a place to park? And you drive around and around and around looking for that empty spot. And when you see one, you say, "Oh, goody, there's an empty spot." But then, when you get ready to pull into the spot, you discover that there's a sign saying, CVS customers only. In other words, that particular parking space is reserved for CVS customers. And if you aren't a CVS customer, you can't park there. Now, when you go to the strip center, most of the parking spots are full. Your problem is that there aren't enough empty ones. Ooh, but when it comes to your boning at post-menopause, you have the opposite problem. Your bone has hundreds of estrogen parking spots that are empty because you have no estrogen. Or maybe you're taking some estrogen, but it's just not enough to fill all the spots. So even though you have some estrogen, it's not enough to fill all the estrogen parking spots. And when it comes to the parking spots at the strip center, there are exceptions to the rules as to who can park in certain spots, aren't there? For instance, a handicapped person can still park in the CVS-only spot. Likewise, the estrogen parking spots in your bone make exceptions as to the kinds of things that can park in an estrogen parking spot. And that's where the SERMs come in. SERMs are the exception to the rule that only estrogen can park in an estrogen parking spot. The estrogen parking spots selectively allow other molecules to park there. Same thing on this side. So, that's why the word selective is part of the name for these medications. It's the S in the acronym SERM. So now you have an understanding of the first three words of the name selective estrogen receptor. SERMs are non-estrogen molecules that can park in estrogen parking spots in your bone. Now, the last thing you need is an explanation of what they do once they park there. That will explain the M in the acronym SERM. After a SERM is selectively allowed to park in an estrogen-only parking spot, it causes some changes in the cell to which it is attached. Well, another word for change is modulate. And anything that modulates a situation is called a modulator. So SERMs can cause change. In the very first video on osteoporosis, you learned that estrogen loss causes bone loss. And since then, you've also learned that estrogen replacement prevents bone loss. So when an estrogen molecule parks in the estrogen-only parking spot, it causes a change that prevents bone loss. It modulates the situation. Well, SERMs are estrogen imposters. They imitate estrogen. And since they imitate estrogen, the changes they cause are similar to the changes that estrogen causes. In other words, SERMs can do some of the same things estrogen can do. And preventing bone loss like estrogen does is one of those things. So SERMs modulate the estrogen parking lot in the same way that estrogen does to decrease bone loss. So the last word of the name SERM is modulator. The bottom line is that selective estrogen receptor modulators are non-estrogen medications that can park in the estrogen parking lots in your bone and do the same thing that estrogen does for your bone. Ladies, this is huge. This is a wonderful thing for any of you who need to avoid or treat bone loss and cannot or will not use estrogen to do so. And some of you may even need a SERM in addition to estrogen. So now I'll list the actual SERMs, and I'll list them in order of popularity. The SERMs for your bones are the bisphosphonates, which include alendronate, risedronate, ibandronate, and zoledronate, and raloxifene, tamoxifen, bazidoxifene, and denosumab. So let's go through these one by one. For each, I'll tell you what you need to know in order to weigh the benefits against the risks as they apply to you. And here's the chart we'll fill in. What you see is the skeleton of the chart we'll create. Along the top row, you see the category of drug in the first column, the actual drug in the second column, the pros in the third column, the cons in the fourth column, the limitations in the fifth column, side effects in the sixth column, and whether you lose bone after stopping treatment with the drug in the seventh column. These are all the things that will be important in determining your preferences if you consider using any of these non-hormonal medication options for preventing or treating osteoporosis. The most widely used SERMs for prevention and treatment of bone loss is the group of products called the bisphosphonates. They form an entire category of options all by themselves. They are the grandmother of SERMs for your bones. And for any woman considering a SERM, the bisphosphonates are the first SERMs you should consider. The chemical names of these medications are long and complicated, but you may be familiar with some of their brand names. Bisphosphonates include all of the following. There is alendronate, which is Fosamax, which is all of these, and Benosto. Next, there's risedronate, which is Actonel or Atelvia. Next is ibandronate, which is Boniva. And finally, there's zoledronate infusion, which is also known as Reclast or Zometa. Now, all of these can decrease your risk of spine fracture by 40 to 70%, and they can decrease your risk of hip fracture by 20 to 35%. One of the interesting things you'll notice about different SERMs is that they tend to work better on one part of your body than another. Some are better for preventing bone loss or preventing fractures in your spine, while others are better for your hip. And sometimes that difference is enough to make you choose one over the other. Sometimes it's not. And even within the group of bisphosphonates, different medications may be more beneficial for one part of your body than another. For instance, alendronate is best for your hip. Ibandronate is best for your spine. And risedronate is good for bone. Bisphosphonates are available by mouth or by the intravenous route. The oral route is much more popular. The most significant thing about the bisphosphonates is that they can irritate your esophagus. And because of this, there are strict rules about how you have to take them. All bisphosphonates require you to take them first thing in the morning, the minute you wake up. But you have to sit or stand up, take the bisphosphonate with a very large glass of water, and remain sitting or standing for 30 to 60 minutes, and refrain from eating for 30 to 60 minutes. Because of these requirements, there are bisphosphonates that you can take once a week or once a month instead of once a day. The side effects of bisphosphonates are musculoskeletal pain, atypical fractures of outer cortical bone that surrounds the trabecular bone for which you take the bisphosphonates in the first place, and osteonecrosis of the jaw. Now, people usually react strongly to these side effects. They think, why would I take a medication that could cause a fracture? And the answer would be because the kind of fracture you'd have as a side effect of the medication would be nowhere near as bad as the kind of fracture you'd have without the medication. And there have only been 249 cases worldwide of atypical fractures. And some people recoil about the possibility of osteonecrosis of the jaw, or ONJ. Osteonecrosis of the jaw is a situation in which your jawbone deteriorates over time. It's usually about 10 years after taking the bisphosphonate that you lose some teeth at the back of your mouth. But again, when women go, why would I take a drug that would cause my jawbone to deteriorate? Osteonecrosis of the jaw is very rare in women taking bisphosphonates to prevent or treat osteoporosis. The incidence with using them for prevention or treatment of osteoporosis is 0.7 cases per 100,000 users. It occurs much more commonly in patients taking it in much higher dosages for other diseases, like cancers. But even then, the incidence is only 1 to 10%. And if you have to choose between some jaw deterioration and a fracture from osteoporosis, I hope you realize that the fracture from osteoporosis is much, much worse. Everything is about priorities and trade-offs. The injectable bisphosphonate zoledronate, also known as Reclast or Zometa, can cause some flu-like symptoms. Now, another interesting thing about bisphosphonates is something called a drug holiday. Now, I think drug holiday sounds like something people would do for fun that involved the use of recreational drugs while on vacation. And being the nerd that I am and having never tried a recreational drug, I think it sounds horrible. But alas, that is not what drug holiday means. Instead, it means taking the bisphosphonate for a few years and then taking a break from it before resuming. And that's something each woman has to address personally. There is no rule that you have to stop bisphosphonates. It's just an option after about 3 to 7 years of therapy. And I just thought you should know that there is something called a drug holiday. It does not imply that anything is wrong. But most women who take bisphosphonates may consider stopping them altogether at some point. Do you remember what happens to your bones if you stop taking estrogen? The same thing that happened in reaction to the disappearance of your estrogen at postmenopause. You start losing bone. So do you think it's different for the bisphosphonates? Unfortunately, it isn't. If you stop taking a bisphosphonate, you will start losing bone. But the degree of bone loss is not as fast as it is after stopping or losing your estrogen. You'll maintain your higher bone density for at least 1 year. But after that, you'll start the downhill slide to bone loss again. It's like I've told you about estrogen. These drugs only prevent loss while you're taking them. Now, the dosage of a bisphosphonate may differ depending on whether you're taking it to prevent osteoporosis or to treat osteoporosis. Generally speaking, the treatment dosage is about double the prevention dosage. One of the biggest advantages of the bisphosphonates is that they are the only SERMs that you can take with estrogen. For all the others, it's either the SERM or the estrogen, but not both. But one of the biggest disadvantages of the bisphosphonates is that unlike all the other SERMs, they only benefit your bones. They offer no perks like decreasing your risk of heart attack, breast cancer, or uterine cancer, or any of your menopausal symptoms. So you can see that the bisphosphonates do some good things and some not so good things. That's the name of the game, trade-offs. Your job is to choose the options that are best for you. So now let's fill in our chart with all this information about the bisphosphonates. Notice that I've divided the bisphosphonates section into the individual drugs within that category and designated their differences. The next most popular SERM for preventing and treating osteoporosis is raloxifene. You may know raloxifene by the brand name Evista. Raloxifene is very easy to take. It's just one 60 milligram tablet daily, any time of day. Raloxifene is most beneficial in preventing spine fractures. It decreases your risk of spine fracture by 25 to 50%. But it increases bone density in both your hip and your spine by about 2 to 3%. A special perk of raloxifene is that it also decreases your risk of breast cancer. Now, this is new information. Previously, it was thought to have no effect at all on your breasts, but now we know that it has a beneficial effect on your breasts. Side effects of raloxifene include hot flashes, night sweats, joint pain, headaches, and leg cramps. So raloxifene can actually worsen your symptoms of menopause. And a big disadvantage of raloxifene is that it increases your risk of blood clots. It does so to the very same extent that estrogen does. And this increased risk of blood clots is why you can't take both raloxifene and estrogen together. Are you starting to see that each option has both benefits and risks? This is why you have to tailor everything specifically to you. Another perk of raloxifene is that it decreases your lousy LDL and increases your healthy HDL, so it can help prevent a heart attack. And like the bisphosphonates, your increased bone density will start to decrease when or if you stop taking raloxifene. So you see that there are some common themes with the SERMs. And here is raloxifene on our chart. The next SERM is one with which you may be familiar for a different reason. It is tamoxifen. Now the brand name is Nolvadex, and it's really a medication for treating breast cancer. But it just so happens that tamoxifen also prevents osteoporosis. That's why it's an option here in the osteoporosis unit. Oh, and it decreases your risk of heart attack too. Now before you go and get all excited, remember that everything, absolutely everything, has both benefits and risks. Nothing is perfect. The big risk with tamoxifen is that it thickens the lining of your uterus. So if you still have your uterus when you take tamoxifen, you have to undergo uterine surveillance on a regular basis. Doesn't the term uterine surveillance sound like spying on your uterus? And actually it kind of does involve a form of spying, because uterine surveillance consists of getting an ultrasound and a biopsy of your uterus on a regular basis. The ultrasound is painless, but the biopsy is not. Side effects of tamoxifen include visual disturbances, hot flashes, just like you saw with raloxifene, and blood clots, just like you saw with raloxifene. So tamoxifen is advantageous for its beneficial effects on your bones, breast, and heart, but it is disadvantageous for its detrimental effects on your uterus, blood clotting risk, and symptoms of menopause. Don't you just hate it that there isn't just one that's perfect in every way? Time to put tamoxifen on the chart. Now we have a new option that is sort of a hybrid. At the beginning of this video, I told you that the non-hormonal options for preventing and treating osteoporosis were SERMs. By definition, SERMs are not hormones. They can park in the parking spots for hormones, and they behave like hormones in some ways, but they are not hormones. However, the next option for preventing or treating osteoporosis falls into a category all its own. It is both a hormone and a SERM. Actually, it contains both a hormone and a SERM. The name of this product is Duave. It consists of estrogen and a SERM by the name of vasodoxifene. So you learned earlier in this video that the bisphosphonates were the only SERMs that you can take with estrogen. And this newfangled medication actually contains both a SERM and estrogen. And the two together serve to prevent bone loss. How well does Duave prevent bone loss? Well, it can increase your bone density by 1 to 5%. But don't forget that this product is new. Always take into account that less is known about a new product. But it is very important for you to know that the dosage of estrogen in Duave is lower than the minimal necessary dosage designated by the estrogen window of opportunity for preventing heart attack and Alzheimer's disease. And while you've learned that you have to take progesterone with estrogen if you have a uterus, this product enables you to skip the progesterone. That's appealing to many women who hate the side effects of progesterone. Somehow, the lower dosage of estrogen combined with the SERM prevents the thickening of your uterine lining. The disadvantage of Duave is that it only alleviates one symptom of menopause, vaginal dryness. It may alleviate your hot flashes too, but do not expect it to alleviate all your symptoms like estrogen does. And the possible side effects of Duave are muscle spasms, nausea and vomiting, indigestion, diarrhea, abdominal pain, sore throat, dizziness, and neck pain. Consistent with what you've learned about both estrogen and the SERMs, you will start losing bone when and if you stop taking Duave. And now it's time to chart Duave. Finally, we have denosumab. Its brand names are Prolia and Jiva. It's totally different from the other options I presented thus far because it's not a SERM at all, but it is a non-hormonal medication option. It's an antibody that interferes with the cells that break down your bone. You take denosumab as a subcutaneous injection every 6 months. It's very effective and decreases your fracture risk of all fractures by 32%. This product has been available since 2010, so it's not new, but it's newer than all the options other than Duave. And like all the other options, denosumab only works while you're taking it. When you stop it, you start losing bone. And you do so in the very first year that you're off of it. Side effects of denosumab are back pain, musculoskeletal pain, cystitis, which is inflammation of your bladder, increased cholesterol, and skin infections. But there is no reason that you have to ever stop it. So finally, we're adding denosumab to our chart. The chart is kind of pretty, isn't it? You can print out this chart for yourself by either clicking the link just below the screen you're watching or by going to menopausetailor.me in the YouTube Videos Tutorials tab. So there you have all your non-hormonal medication options for preventing and treating osteoporosis. And one of the questions you might have is whether you can take more than one of these at a time. And the answer is yes. But more commonly, women use one after another. For instance, because all of these only work while you're taking them, and because some of them have side effects that you want to minimize, it would not be uncommon for a woman with osteoporosis to take raloxifene for a few years, and then switch to a bisphosphonate for about 5 years, and then take denosumab forever. And somewhere along the way, she may take one of the hormonal medication options that I presented in video 222 instead of or with one of these. You just have so many options. Knowing all these options gives you many ways to avoid both osteoporosis and the fractures that result from it. Don't settle for believing that osteoporosis and fractures are your destiny. So here's our combined chart again with all the cells filled in. Finally, as I've done in the previous videos on treatment options, here is the T-score bone density scale showing you where these non-hormonal medication options contribute in managing osteoporosis. Notice that unlike estrogen, these non-hormonal medication options are not for prevention of osteoporosis. You use them for successful intervention and fixing of osteoporosis. But unlike estrogen, you would not use any of these just to prevent osteopenia or osteoporosis. Here's how estrogen appeared on the T-score scale in video 222. So of all the options for managing osteoporosis, the products I presented today are the closest to estrogen in their abilities, but estrogen is the only one that can do everything for your bone and alleviate all your symptoms of menopause too. It's just so great that you have so many options, and there are new ones being developed all the time. Next week, we'll address the guidelines for how doctors use these options. So this is where I'll sign off for today. This video was long. Go to menopausetailor.me to schedule consultations, subscribe to my channel, follow me on Facebook, Twitter, and Instagram, and come back in a week. Bye, ladies.